Okay. Just making sure. Okay.
Yeah. Okay. Good afternoon, everybody. I'm sitting down like this. I prefer to be standing, but because this is being recorded, I thought my voice should be closest to it. In any case, I am Martin Jeetzy. I am the director of the Cerebrovascular Diseases Program here at Hackensack University Medical Center. I am a neurologist and a vascular neurologist, and am working with lots and lots of people here to get us certified as a comprehensive stroke center. We'll talk a little bit about that in the course of this presentation. This is a very practical presentation having to do with all the things I would like you to be doing regarding stroke care. It is therefore somewhat less academic than you might otherwise want, but I'm happy to entertain any questions about guidelines or what should actually be done in certain circumstances. So don't hesitate to stop me at any point. So I want to give you an overview of the stroke program, the stroke care guidelines, references, I'll define what those are, and order sets, an overview of new and upcoming changes to the guidelines and order sets that aren't yet in place, an overview of our stroke quality metrics, and some tips for documenting stroke care decision-making. So first of all, stroke programs. Hackensack Meridian Health has 12 state-designated stroke centers. So the state, through the licensure process, designates hospitals as either comprehensive stroke centers or primary stroke centers. HUMC, like JFK and Jersey Shore, is a designated comprehensive stroke center, and the other 9 are primary stroke centers. And they're arranged somewhat in a hub and spoke arrangement, with the primaries feeding in the complex cases to the comprehensives. So we are still here at HUMC certified by the Joint Commission as a primary stroke center, and will be going for certification as a comprehensive stroke center in 2019. That's this year, in October, in fact. So it is very important that you, as stroke providers, because we all are caring for these patients, will help us achieve and maintain those certifications. And it is, of course, all evidence-based guidelines which feed into order sets, which feed into the care that we provide on a practical basis. In terms of the distinction between comprehensive stroke centers and primary stroke centers, primary is really focused on ischemic strokes, and in particular, thrombolytic agents, TPA, alteplase. So how do you get it in quickly? Where do you take care of the patient after that? That's the focus. Comprehensive stroke centers care for what are called more complex strokes, which to me is a meaningless term, but it includes large vessel occlusions, which are treated with thrombectomy, subarachnoid hemorrhages, which are treated with aneurysm clipping or coiling, endovascular coiling, and intracerebral hemorrhages, which are treated, if at all, using decompression of the hematomas. And all of that has in common the need for neurocritical care. So that's the common theme, is neurocritical care units and trained neurocritical care providers at the comprehensive stroke centers. To give you an idea of our volumes, this was 2018, which was a low volume year. We had 561 acute ischemic strokes, 119 intracerebral hemorrhages, 54 subarachnoid hemorrhages, and 34 TIAs. This year, I think we're seeing about a 15 to 20% increase over those numbers. So about 1,000 strokes all told when you count them all for this year, I believe. TPA volume was also somewhat low last year, 51 infusions, which represented, as you can see, less than 10% of the ischemic strokes. The target there is generally around 20% of the ischemic strokes should be treated with TPA. There were 76 thrombectomies, so maybe 15% thrombectomy rate. Again, we expect that to be at about 20. And the aneurysm volume, 85. Now notice 85 is larger than the 54 subarachnoid hemorrhages, because not all aneurysms rupture. You might catch them incidentally or in the course of a nerve palsy workup. I believe we're on track to do about 100, 110 this year. So in terms of the new staff, there's me. I've already introduced myself. Dr. Rosengart is the Director of Neurocritical Care. That is an administrative position, so you will not see him or his successor, Dr. Patil, taking care of these patients themselves so much as helping us to write clinical practice guidelines and order sets. And then finally, some of you have met Shobana Joseph, who is the advanced nurse practitioner for the stroke program. She does participate in the care of the patients as well as advising and educating nurses about the care of those patients. So for the spring, which has already passed, we created the dedicated stroke service. And by the stroke service, I'm referring to the neurology side of the stroke service. These are, for the most part, vascular neurologists, which is an added fellowship after neurology, who function as neurohospitalists, by which I mean when we are on service, we are in the hospital, we're not doing anything else. We don't have to run back and forth between a clinic or any other hospitals. We do not each work continuously for 7 days at a time. So we will be on service for 7 days, but we also share in a rotating call schedule at night. So it might be me for 7 days, 8 to 5, but then it'll be some of my colleagues the other evenings. So there are now separate general neurology call schedule and stroke neurology call schedule, which you will see in the MION app. We are about to implement Telestroke, which sounds like a big change, but hopefully will not practically be a big change. We can respond to stroke codes via telemedicine. And the common theme is that anytime a stroke is suspected, the first thing you should be doing, outside of making sure the ABCs are all stable, is to rush them to the CAT scanner. So at both the ED CAT scanner and the main hospital CAT scanner, we will, by August 5th, have robots. Now, these are not sort of Danger Will Robinson robots, but they look like computer carts, but it has a pan, tilt, zoom HD camera on it, which the neurologist can control remotely. And it has a big screen on it whereby the patient can see the neurologist. And it enables us to perform the National Institutes of Health Stroke Scale, the NIHSS, for these patients. It is, as for those of you who have seen it, you know, it's a very simple examination. It takes about 7 or 8 minutes to complete. And we can do all of that remotely. The only thing we need help from a nurse for is the visual field examination and the pinprick examination. So in any case, Telestroke will be implemented with the aim of getting the neurologist to the bedside within no more than 10 minutes from the stroke call. Usually it can be around 3 minutes. So I get a phone call, it goes straight to our cell phone. Hi, we got a patient, we think it's a stroke, we're heading the patient to this CAT scan right now. I say, great, tell him to turn on the robot. I walk over to my computer at home, or my iPad, or my phone, but preferably a computer, and turn it on, and I am there immediately. So that is the value of Telestroke. Otherwise, the process doesn't change. It changes for the nurse because she has to help with some of the exam, but the process does not change. The next big change is the development of a stroke unit. Now, we have had 3PW designated as the stroke unit apparently for a number of years, but I would ask the stroke service of the 21 patients you have, how many of them are on 3PW, and I would bet the answer is 2 or 3. So they're really not going there. We are looking to create an actual geographical stroke unit, and it looks like it will be 3 North. And so on 3 North will be both the stroke unit, which is a step-down level unit, and a part of the neurocritical care unit, which is a critical care level unit. You may already know that we separate surgical stroke neurocritical care from medical stroke neurocritical care based on SICU and MICU. So hemorrhagic patients all go to the SICU. Ischemic patients may often go to the MIC. We'd like them to be going to 3 North. So that's a change that is coming up in August. And then the final big change just really deals with the emergency department. When EMS, usually it's the ALS paramedics, call and say, we have a stroke coming in. We want the ED to call us then and say, there's a patient coming in. Get here now, or get on the robot now, so that we can meet the patient as they arrive. So the stroke service was created May 28th. I talked about it being a separate inpatient stroke service. We're in-house 8 to 5. We do stroke admissions ourselves. I haven't seen an awful lot of that, but we do admit some of the patients to our own service. We provide stroke consultation for the majority of the patients, and we respond to code strokes. But to be clear, the stroke team is not the code stroke team, or it is not just the code stroke team. It is also an admitting and consulting team. Telestroke starting, this was my optimistic presentation, starting late July. It's actually starting probably August 10th. As I said, the robots are stationed at the CT scanner. In the event that we are not finished examining the patients or fully making all the decisions at the time they leave CT, the robot can be dragged along with the patient. We may continue the consultation anywhere in the hospital, but for the most part, it'll just happen in the ED. We will not be using the robots to do rounding. Stroke unit, as I just said, going to 3 North. Neurocritical care unit, so that will be split between some designated beds in the surgical ICU. So there'll just be signs saying this is a neurocritical care bed, so not a real change in process, and the beds in 3 North, which will be part of the medical ICU. To be clear, neurocritical care is not just stroke. There's also post-craniotomy patients, refractory status epilepticus patients, meningitis, Guillain-Barré syndrome, so on. Pre-notification, I already talked about this, the code stroke. While the code stroke is called, that thing that results in a page, while the code stroke is called by the ED physician after the patient arrives, neurology will be notified in advance to say, we have a potential stroke coming in, get here. Once we see the patient, or the ED physician sees the patient, says, aha, yes, this is not trauma, this is not alcohol intoxication, this may well be stroke. Then they call the code stroke, which clears the CT scanner and gets a pharmacist, etc. The code stroke process, both inpatient and outpatient, is called for patients who are less than 24 hours from last known well. So I will emphasize that this is not just a TPA code, because that window only goes out to 4.5 hours. But the thrombectomy window goes out to 24 hours. We'll talk a little bit more about that. So the code stroke process goes out. That is true for both inpatients and ED patients. And part of that code stroke process is calling the neurologist on the cell. So it's not a page, it's a call. You get us immediately. And I will also point out that the code stroke order set includes CT of the head, CT angiography of the head and neck, and CT perfusion of the head on all patients, irrespective of time, out to 24 hours. So frequently I'm getting calls saying, hi, I'm on the RRT team. I think it might be a stroke. I was thinking I'd get a CAT scan of the head. I said, thank you for thinking about stroke, but please get the code stroke order set, click it, sign it. It will get you a CT, CTA, CTP. We're trying to get all that done fast. So, that in mind, we do have revised order sets. We have already rolled out the revised code stroke order set, which among other things has this triple scanning protocol. There is an Alteplase for stroke order set. That's really just for neurology. We're the ones who are supposed to be ordering it, and we're not just saying Alteplase at this dose. We're saying Alteplase plus vital signs and neuro checks and nothing by mouth during the infusion, et cetera, et cetera. There are also revisions being made to a hemorrhagic stroke order set. That's intracerebral hemorrhage. Subarachnoid hemorrhage order set, aneurysmal, and post-thrombectomy order sets. They should be out by September. And then we have written a draft of a TIA observation order set, and that will roll out by the new year. So the stroke order sets are very narrowly focused on the evidence-based clinical practice guidelines, and in fact, the clinical practice guidelines that were published by the American Heart Association over the past several years. They are reviewed annually by the stroke, what are we called? Not the Stroke Care Committee, something like that. We have a committee. I chair it. I should know what it's called, but I don't. And it's the providers in critical care and radiology and neurosurgery and whatever else is relevant. And we decide what should be included in the order sets based on the clinical practice guidelines, as well as whatever problems we've been having here at HUMC. The reviews do go out, are pushed out to all of the HMH hospitals, by the way. So should you be at another hospital, the order set should look the same. I will point out that there are a number of elements on the order set that are pre-checked, like the CAT scan. And this admission, aspirin, I believe, is pre-checked. Atorvastatin is pre-checked. These are all things that we feel are very important. These are, you must do the following, unless something comes up. So if you're going to uncheck it, be prepared to give a reason in the chart for why you didn't prescribe a statin, why you didn't start the patient on an antiplatelet agent, or why you didn't scan the patient. So that ties into the get with the guidelines quality measures. So these are measures that are endorsed by CMS, the Joint Commission, who knows who else, or certainly the American Heart Association, that constitute good care. So that's like giving aspirin to a patient with an acute stroke within 24 hours. It's really before second midnight. Or giving a statin or, to any ischemic stroke or TIA patient, et cetera, et cetera. So there are core measures which we report to the Joint Commission. There are the guideline measures which overlap with that, but there are some additionals that allow us to have scorecards about how well we're doing. And then there are comprehensive stroke center measures. So there's an additional 8 or 10 measures that we have to fulfill. So we perform well on these measures, but not beautifully. We're aiming for beautifully. So you will be getting feedback from me probably about, we really needed this to be done, why wasn't it done? Or can you go back and document why you didn't do something? Examples. Thrombolytic therapy, that's TPA. For any patient, the measure is patient who arrived by 2 hours must be treated by 3 hours, which is a funny way of saying sort of you should aim for 60 minutes. But the truth is, with that measure, you could arrive at 1 minute after and get treated at exactly 3 hours, and you'd still fulfill the requirement for this one. Our goal is really to give TPA within 30 minutes. There is another measure of time to TPA within 60 minutes. 60 minutes is now considered small potatoes. As I said, we really want to get it within 30 minutes. The awards that are given by the Get With The Guidelines folks at the Heart Association are really for patients treated within 30 minutes, 45 minutes, and 60 minutes. And for the Honor Roll Elite Plus, you need 30 minutes for a majority. We have to get an NIH stroke scale score on patients, all of the patients. We have to order VTE prophylaxis. We have to get early antithrombotics. That was aspirin by end of day 2. We have to counsel patients about smoking cessation. We have to assess them all for rehab. If they have AFib or aflutter, they have to be discharged on anticoagulation. Otherwise, they have to be discharged in an antithrombotic. So you will note that these are all things that I was saying were pre-checked, or mostly things that are pre-checked in the order sets. So message number 1 is use the order set. So resources, yes?
Going back to that order set, on the smoking cessation, I don't know if the residents know that we have smoking cessation consultation that will come to the bedside.
Awesome.
So we have a whole system here under Dr. Paula Portino, where if you have a patient who's had a stroke and is a smoker, they will come to the bedside, initiate smoking cessation counseling, and enroll them in a program to stop smoking. All funded, externally from the state. I just wanted
Is
to
there
give a plug.
a specific order for that? What does the one write?
Actually, I will send. There's a phone call, but
Mhm.
I'll get that out to everyone.
Great, thank you. So resources, I'm your primary resource. Don't hesitate to email me, call me. My cell phone's on. Am I on? Anthony Rocco is the stroke coordinator. He's not at the bedside, but he is the source of all knowledge about things stroke at HUMC. And Shobana Joseph, who's the stroke nurse practitioner, she rounds with the team. She's more of a nursing resource, but she's available for questions from anybody. So I'll give you some stroke order set highlights. The code stroke order set is really focused on preparing the patient for either thrombolysis or thrombectomy. As we said, about 20% of those patients are actually going to get one of those. So there's the CT, CTA, CTP. That's part of that. I will also point out it's a little bit obscure, but I'm going to bring it up because it may come up, that the way that the published guidelines are written, that in order to give a patient TPA for stroke, you must get the blood pressure below 185 over 110. But then it says during the infusion, you must keep the blood pressure below 180 over 105. So you say, okay, and you give the bolus, and then immediately alarm bells should go off that you have to drop the pressure 5 points more, both diastolic and systolic. So we said, enough of this nonsense and the confusion, let's just go with 180 over 105. So if anybody's reading that closely, that's fine. There's an alteplase for stroke order set, which I said neurology should be writing. It allows a couple of boluses of labetalol to get the pressure down below that level that we just discussed. After that, we go to nicardipine. And usually, if you give the one bolus and they're still even close to the threshold, we usually go straight to nicardipine. It also talks about how the normal saline flush following alteplase has to be given, which helps make sure that the entire dose is given. The stroke and TIA admission order set, which should be very important to all of you, is something I want to emphasize here. I will point out that telemetry is pre-checked and should be used for all patients with any stroke diagnosis for a minimum of 24 hours. I'll point out that bed rest is not necessary for most patients. It's still there in the alteplase order set over my objections, but anybody else, don't keep them in bed. We want them mobilized as quickly as possible. It's good for them and they hate being stuck in bed. NPO is not necessary for these patients. They used to be on an NPO for 24 hours. There's no reason for that. So that has gone away. You may have to reinforce that with nursing. For patients who come in after 24 hours from last known well and who therefore do not get a CTA of the head and neck, there's no reason that we have to do CTAs on everybody, and nor is there a reason we have to image the vasculature in the head, so a carotid Doppler is fine in most of those patients. But if they've had a CTA, we certainly don't need a carotid Doppler. Okay, we don't need to repeat that. Occasionally vascular surgery needs it for some reasons, but generally no. MRI of the brain is not always necessary. It is sort of reflexive for us, the neurologists, to just get an MRI in everybody. But if a patient has a small vessel stroke and you can see it on the CT, you're done. A patient has a big vessel stroke, a large vessel stroke, and you can see it on CT, you're done. It's really more in the situation where you're saying, could this be cardioembolic? May there actually be multiple areas of stroke that we'll see on MRI? Or the CT was negative, and I just don't know, is it too small to show up on CT, or is it actually not a stroke? So those are the situations in which we do proceed with MRI. Echocardiography is not necessary for every patient. If you know what the cause is, again, small vessel stroke, presents as a lacunar syndrome, you see it on the MRI, you don't need an echo. It's not going to help you make a further diagnostic decision. If a patient has AFib, you probably don't need an echo. You already know you're going to put the patient on anticoagulation. If you, as internist or cardiology, thinks that there's a reason to additionally get an echo for other information, go for it. But we took TEE. We took TE and TEE off because we didn't want people to think we were emphasizing the need for an echo in every patient. TEE should really be reserved for very special circumstances. I think we all overuse it a little bit. I'll talk about that more in a minute. The LDL is pre-checked. Please do not uncheck it. We have to have an LDL checked on all patients within the past 30 days. So if you see one within 30 days, then you can uncheck it. Otherwise, just let it go through. Even if you're going to give a statin, let it go through. Atorvastatin 80 is a preferred statin for patients under age 80. I have always advocated for reducing the dose over age 80 to 40 milligrams. I've been challenged appropriately by folks in the ICU with literature saying there's no evidence that you need to reduce the dose, and that's true. So whatever you want to give, 40 or 80 to the older folks, make sure you give them something. And then pharmacologic DVT prophylaxis is recommended for most patients. It's not pre-checked. Sequential compressive devices are pre-checked, but we would really like enoxaparin or heparin on those patients as well. It's more effective. It's not contraindicated except in the first 24 hours after thrombolysis and before you've shown stability of an intracerebral hemorrhage. But we give it to patients with intracerebral hemorrhages. We give it to patients with subarachnoid hemorrhages. And we give it to TPA patients with hemorrhagic conversions. Right? It's still valuable and does not contribute to increased bleeding. Antiplatelets and anticoagulants, as I've said about 10 times already, we need to give an antithrombotic to our stroke and TIA patients by the second midnight. It's one of our quality care measures. You can use aspirin, you can use Plavix, you can use Agrinox. There are others to choose from, generally not really necessary. A common question is, if a patient has a stroke on aspirin, should I switch the patient to something else? And the answer to that is, I'd understand that you'd want to. I generally want to, but there's no data to indicate that it helps. That switching between antiplatelet agents is beneficial. Anticoagulants, whether it's a full dose heparin, low molecular weight heparin, warfarin, or NOACs, those are reserved really for patients with a fib, a clear cardiac cause, so an extremely low ejection fraction, a thrombus seen in the left ventricle. It is not appropriate for patients who have embolic stroke of undetermined source. So patients who say, gee, this looks embolic, but I haven't proven that there's a cardiac source. But certainly patients with AFib or aflutter must be discharged on an anticoagulant, or you have to give a reason why not. Contraindications for antithrombotics, there are many reasons, like allergies, aortic dissections, bleeding disorders, terminal illness, etc. Keep in mind that the person who abstracts our charts cannot make any inferences. So if on the page it says, patient has active GI bleeding, and then it says patient has AFib, and there's no administration of an anticoagulant, she has to code that as a fallout. We, the physicians, are obliged to say, we're not giving anticoagulation because of the active GI bleeding. We have to link those, they cannot. So you have to explicitly document your rationale. Antiplatelets and anticoagulation at discharge, one of the core measures. For patients with AFib who have had a large infarct and you're saying, I don't want to give the anticoagulant yet, or let's say hemorrhagic transformation, you can't say, we'll defer to the PCP or the nursing home or the inpatient rehab facility. You have to say, start anticoagulation on such and such a date, or day 10 post-stroke. You have to explicitly give it. So you can schedule a delayed start, but cannot defer the decision. Otherwise, that is a fallout. Yes?
The idea of conversion to hemorrhagic stroke, if it's a large area, applies to just antiplatelets as well, or just?
So the data on antiplatelets, right? It is a separate question than the anticoagulants. The data on antiplatelets are that antiplatelets do not, in fact, contribute to worsening of hemorrhagic conversion. So really, there is no reason to delay an antiplatelet. It's really just the anticoagulant. So I misspoke. Thank you for asking.
No, just you didn't.
Or if-
Sorry.
If I pushed you in the wrong direction. So yeah, antiplatelets, you can start whether there's hemorrhagic conversion or not. Additional reasons for not prescribing antiplatelet or anticoagulant: discharge, frequent falls. Again, I'd still always go with the antiplatelets if needed, but the anticoagulants you could do for frequent falls. And if the patient has a Watchman device, then they don't need it. You can say that is your reason.
And then if someone comes in with a hemorrhagic stroke,
Yes.
usually due to longstanding, right, uncontrolled hypertension or something. So
Yes.
at some point down the road, you start an aspirin. That
So for a patient who has a spontaneous intracerebral hemorrhagic stroke, if they have, the challenging ones are the patients who have AFib, who then have an intracerebral hemorrhage. If they had it because of warfarin, we may actually put them on a NOAC after a few weeks. If they were not on any anticoagulant, we will go ahead and put them on an anticoagulant after a few weeks. If they have a mechanical mitral valve, you might start them on an anticoagulation within 24 hours, as soon as the bleeding stops. But in terms of aspirin, we might decide not to give that patient aspirin anymore if we think they have a predilection to intracerebral hemorrhage. It can be really tough, though. Patients with cerebral amyloid frequently have both ischemic and hemorrhagic stroke. And it's really painful not to put them on antiplatelets, but generally we do not. As I said before, get a lipid panel on everybody. It does say that you don't necessarily have to if the patient arrived on a statin and you will be continuing that statin. I'd say to be safe, just get an LDL. It's not an expensive test. I'm even saying that out loud. I don't think it's a terrible waste. You must prescribe a statin to any stroke or TIA patient, ischemic stroke or TIA patient, who has an LDL greater than or equal to 70. So if you do the LDL and it's 56, you don't have to prescribe a statin. No problem. But if they came in on a statin and they're below, you should continue them on whatever they were on. Contraindications can be myalgias, liver dysfunction, allergy, I suppose. If the statin is listed in the allergy section, you do not have to document why you didn't give it. Otherwise, you must explicitly document. So my general advice is please explicitly document if you are not giving a statin. Blood pressure management. For the most part, we allow permissive hypertension after ischemic stroke or TIA. And permissive hypertension means we don't treat until the systolic gets over 220 and the diastolic over 120. So most of the time we're just taking patients off their antihypertensives when they get in the hospital. The exception is for the patients who are getting TPA, and for that, at least in the first 24 hours, we want them less than 180 over 105. That period of permissive hypertension usually extends out to about 48 hours. The range is anywhere from 24 to 72 hours. So at that point, we're usually reinitiating their home blood pressure medications. For those patients who are getting over these limits, we are usually using IV labetalol or nicardipine infusions. Nicardipine is just our favorite in terms of ease of control and speed. You can, when beta blockers are contraindicated, use IV enalaprolat. Again, most of those patients we're going to nicardipine and don't need it. The hemorrhagic stroke order set's rolling out September 1st. There is an immediate reduction of systolic blood pressure below 180 for all patients. And then we target 110 to 140 for a systolic over the next several hours. So if someone's coming in with a systolic of 240, we would not advise dropping them to 110 immediately, right? You could you can cause them to stroke out. Remember, they've got increased intracranial pressure. So we're saying if they're really high, get them to 180 and then work over the next 6 hours to getting them down to below 140. Subarachnoid, exactly the same blood pressure target. No complication there. TIAs, so this really deals with the patients seen in the emergency department. One of the first things we're doing with those patients after we're trying to determine if they don't actually have a stroke is calculate the ABCD2 score. Now, the ABCD2 score is used to determine, based on age and blood pressure, diabetes, I'll give you the rest in a minute, whether they are at very high risk for actually stroking out in the next few days. If they have a score below 4, their risk is low. I'll give you the statistic in a minute. If it is 4 or above, it's high, and we recommend that they be treated in the hospital. We do so in observation under observation status. The order set will have pre-checked MRI of brain to prove that it's not actually a stroke. Transthoracic echo. I know I said we didn't need echo all the time, but when you're in observation, you want to get things done really quickly. So it doesn't make sense to wait for the MRI and then decide whether you need an echo or not. Most of them will have a negative MRI, so you really are going to need the echo anyway. Carotid ultrasound is fine, and telemetry, minimum of 12, preferably 24 hours. So the ABCD2 consists of age greater than 60 is a point. Blood pressure greater than, systolic greater than 140 or diastolic greater than 90 is worth a point. A sort of classic presentation of unilateral weakness is worth 2 points. If it's just speech impairment without unilateral weakness, it's 1 point. Anything else, like sensory, is worth 0 points. If it lasts more than 60 minutes, that's worth 2 points, because it's probably a stroke and not actually a TIA. If it was 10 to 59 minutes, it's worth a point. If it was less than 10 minutes, no points. And if they have diabetes, they get a point. So the score can range anywhere from 0 to 7. And here's the statistic on the 2, 7, 30, and 90-day risks. Your full resolution photos and videos will not fit on this Mac. Okay. And you can see that with a score of 0, the 2-day risk is 0. In fact, the 90-day risk is 0. When you get to 4, that 2-day risk climbs to about 3.5%. And the 7-day risk, which is really the important one, climbs to 5%. The question is, how quickly can we get a workup done? So patients 4 and above, you can see, are a pretty substantial risk. So for anyone with a 0 to 3, the 2-day stroke risk is 1%, and we're trying to get them seen in our TIA clinic within 2 days. That works for every day except Friday, when they can't get seen on Saturday or Sunday. The rest, yes, the others are seen in observation. That's what I meant to say. So rolling out guidelines, we have 3 types of what I'm calling guidelines, not quite the right terminology. They're the Hackensack Meridian Health Guidelines, which are basically the American Heart Association guidelines cut and pasted onto our own letterhead. So there's a guideline for ischemic stroke, intracerebral hemorrhage, and subarachnoid hemorrhage that's available on the intranet. Then we have HUMC, practical prescribing information. So this is a medication guideline for alteplase, TPA, eligibility in ischemic stroke, and another one for antithrombotic treatment. So this is, when do I use dual antiplatelets? When do I change antiplatelets? When do I use an anticoagulant? Those also available on the intranet. And then finally, references. So these don't rise to the level of guidelines in the sense of having a class 1 level of evidence, a clinical practice guideline, but they do provide literature to support certain decisions about either treatment or diagnosis. So there is one about the emergency management of stroke, which talks about when do we use TPA, when do we use thrombectomy, how do we get out to a 24-hour window on thrombectomy. Well, that's also in the endovascular treatment of stroke, so one refers to the other. Imaging recommendations for stroke patients. When do I need an MRI? When do I not? When do I get the echocardiogram or the transesophageal echocardiogram? And when do I perform a hypercoagulable workup for stroke patients? So those are available, or I'm lying, they'll be available next week. If you go to the HUMC intranet, on the top left, you will see something that says resources. It'll have your name. It'll say so-and-so's links, and under that is resources. Click there. You will then see an area that says JCO, which isn't the correct acronym anymore, I'll point out. Joint Commission resources. And there you will see DSC program CPG, so disease-specific certification programs. And under that, you will see stroke. So new goals for timing, I talked about this earlier. We are almost done here. Our target door to needle is 30 minutes. 50% of patients treated with TPA must be treated within 45 minutes, and I think it's 80% have to be treated within 60 minutes. So we really need the door to physician to be down to 5 minutes, which is why pre-notification is so important from the EMS. Door to CT really has to be 15 minutes at the most. And for thrombectomy patients, door to first pass, not just door to groin, but first pass through the clot should be within 90 minutes. So the code stroke, new time from last known well to code stroke, for code stroke is 24 hours. The imaging panel, as I talked about, is the triple scan. Stroke neurology is called on all cases along with neurosurgery. Thrombectomy decisions are made based on CT perfusion, which I'll show you some pictures of. We go out to 24 hours for anterior circulation stroke and 36 hours for posterior circulation. We already talked about the TIA patients. So patients who have a large vessel occlusion, but we're seeing within 4.5 hours, we still treat them with TPA. So we give them TPA and get them rolled over to the cath lab. They can stop the TPA there. It's got a half-life of like 2 minutes. Patients presenting within 6 hours from last known well with an LVO, large vessel occlusion, do not require a mismatch in order to be treated, but we think that there is benefit from having the study and would sometimes not necessarily proceed, particularly with patients over age 80. The rapid CTP, so rapid is actually an acronym or the name of the type of CT perfusion. Those results are calculated automatically in 5 minutes and sent to our phones. So we get those very quickly. And this is what it sends us. So on the left, you see a scan with fuchsia coloring superimposed over the areas that correspond to where blood flow is less than 30% of normal. So that's area of brain that is dead. No matter what we do, that part is not going to recover. And it calculates the size of that area, in this case 13.1 ml. The right side is the same scans with a superimposed green or chartreuse color, which corresponds to the part of the brain where the time to maximum perfusion is greater than 6 seconds. So that's the areas where the blood is getting there slowly. So if the blood is less than 30%, it's also going to be slow there because it's just not getting there. But typically, the area that's green is larger than the area that is fuchsia because there's some brain at risk. That is the ischemic penumbra. So we would like that ratio, that mismatch between the two, to be greater than 1.8. So in this image, the ratio is 5.6. So what we're saying is there's about 60 ml of brain that can be salvaged if we go ahead and take out this large vessel occlusion now. Yes?
The left-sided fuchsia images, that's over how long? Because that you're saying that that part of the brain doesn't get any blood flow.
So well, I guess that less than 30% of normal.
No,
So out to 10 seconds.
Oh, out to 10 seconds.
So
That's 6 seconds and that's 10 seconds.
Correct. Yes.
So that implies that the rest of that brain, the penumbra, in those remaining 4 seconds was perfused.
Yes. So everywhere else that is not colored got the got its max perfusion within 4 seconds and got the appropriate amount of total blood flow. Yes. So if either the amount that is permanently infarcted is very large or the ratio is very small or both, it's not worth proceeding with the thrombectomy. So in terms of that recommendation about imaging, physician reference, most patients are going to have a CT, CTA, CTP in the emergency department because most of our patients present within 24 hours. TIA patients should have an MRI since we're trying to rule out a small stroke, so that's part of the TIA protocol. Stroke patients may simply have a CT at 24 hours. So you got the CT, CTA, CTP. They say, what's next? Well, in 24 hours, we'll do a CT to determine what the stroke actually was. If you're concerned about the accuracy of the diagnosis, was this really stroke? Or was it postictal, something of that sort? You may want to do the MRI. Or if you're saying, I have reason to suspect this is cardioembolic, I'd like to see if there's multiple areas of infarction, you could do an MRI. And then carotid Doppler suffices for patients who did not get the CTA already in the emergency department. Echocardiography, if the cause of the stroke is already clear, an echo is not necessary, as I said about small vessel disease. And if you already know the cardiac cause, it's not necessary. So TTE is, as I said, recommended for TIAs because it helps reduce the length of stay in observation. And then the hypercoagulable workup, what's valuable in this reference is it tells you what the hypercoagulable workup is, which blood tests you order, but it also says, don't order it, do it as an outpatient. So send the patient to a neurologist and say, this patient needs a hypercoagulable workup, because rarely will the result that you get in the hospital help you make a decision about treatment, change your treatment plan. What examples where it will? Let's see. Arterial, and if you think the patient's not going to be able to get the testing done in the amount of time necessary to make that decision. So a patient's going to a skilled nursing facility, is going to be there for a few weeks, and you think the hypercoagulable workup should be done there, and it's not going to happen, and they're not going to get to see a neurologist in time, you could order it. But I will point out that the protein C, the protein S, and the antithrombin 3 will be falsely normal when there is a substantial clot. So you will get a false sense of reassurance by a negative hypercoagulable workup. The others can be done acutely. It's just an unnecessary expense for the hospital. It's generally reserved, the workup, for patients under age 55 who have no known source for their stroke. So they're not hypertensive, not hyperlipidemic, they're not diabetic, they're young and they get a stroke out of nowhere. Okay, you can start looking. So, summary statements. Please use the order sets for every stroke patient. Stroke/TIA, the one's going to be most relevant to your practices. Please help us ensure that we meet this standard and quality goals by using those order sets. Access the guidelines and references when you need them, and reach out to me or the rest of the stroke service when there are further questions. And that's it. Question?
Question about the 1 to 3 to 6 to 12 rule, starting anticoagulation if you're already on a NOAC. The rule states like 1 day after TIA, 12 days after for a severe large testicular stroke.
Mm-hmm.
That you don't currently follow, you don't use that guideline.
So I would happily refer you to my reference on that, which really makes an argument, and that is about right, by the way, but it more or less says 4 to 14 days after a stroke. So a TIA, go ahead, do it the next day. For an actual stroke, we tend to wait 4 days for the smallest stroke and up to 14 days for the largest strokes. After that, we don't see any increase in the amount of bleeding. And it does depend probably on what drug you use. So warfarin is more prone to hemorrhage than apixaban, for instance. But it's usually that 4 to 14 days.
So I'm seeing something in outpatient clinic, come follow up after a stroke, and I could start them based on that reference.
Absolutely. Yes.
For ischemic stroke, starting statin. Despite the cause of the stroke, we start statin no matter what. For like other preventative measures.
So any ischemic stroke, well, almost any ischemic stroke should benefit from a statin. It is true if you have a patient who had a young patient with a carotid dissection from trauma, you could make the argument. There's really no reason for it in this case. Those are rare, but yes, you could make that argument.
We actually have one of those.
Okay.
Did we?
No, no.
Oh, a young woman who we think is from trauma, but they sent her out on immediate atorvastatin.
Yeah.
And our assumption is they don't know why, or they were hedging as to the cause, right?
Yeah,
There's
or
no
maybe they
rule
were
for
just
statin and healing.
reflexively going along with me. So statins do actually stabilize the endothelial
Oh,
surface.
for the dissection.
Well, in general, they stabilize the endothelial surface. So you might make the argument that it results in some benefit, even in the case of a dissection. I do not know of any evidence to support that theory, though. So there will be rare circumstances where you'll say, it's just not appropriate here. But you need to explicitly give it.
Like an AFib caused stroke.
Mm-hmm.
Because I know I read an article that was like, oh, even in an AFib stroke, it does show to prevent future strokes. So would that be then, it's like a lifelong thing they're not also on? Like,
Yeah, so I do, in fact, for AFib patients do that. I think they generally have cardiac reasons that they ought to be on a statin anyway. So it's not a tough decision for me. Okay. Well, thanks very much.
I have a question.
Yeah.
Say that, a patient strokes on the floor and you're on service and it's at night. and,
Yes.
Is there ever going to be an instance where we have to give it the alteplase because somehow no one can come, like neurology, and we want to meet that 30 minutes or 45 minutes?
So the question, for the people listening to the recording, the question is, if it's an inpatient and there's some reason the neurologist can't get here in time, might the residents or hospitalists be the ones to write for the bolus of alteplase? Well, it's possible. So it might be in a situation where Telly is, in the next 2 weeks, Telly is not available yet, or the internet's down and there's snow on the roads. And so it is possible. And in that case, I'd be on the phone saying, please open up the alteplase order, click this button. Nursing gives the bolus now. They may still say, we don't give the bolus, but they do. They're supposed to. It was rolled out several months ago, but so you don't really need a physician present in my view. But with tele-stroke, we should always be available. But yeah, that 30-minute target is really important. So if in fact I say my internet's down and I'm driving in from the Upper West Side, it would help. It would be better for the patient to get the drug in 30 minutes than to wait for me. It takes me 25 minutes to get here.
I have a question as well. I've had some patients in the ICU where they present with ischemic strokes, but they end up getting anticoagulation within 24 hours and then complicated with hemorrhagic transformation. Some of these patients, they have had a high CHA2DS2-VASc score with AFib. Is a recommendation still to hold anticoagulation 24 hours after the initial diagnosis of ischemic stroke?
Yeah, I would strongly make the case that you should really wait that minimum of 4 days before anticoagulating. The exception would really be for a patient who has a mechanical valve, where that risk is just so incredibly high. You're just got to grit your teeth and do it.
And how quickly would you start anticoagulation? For
24 hours.
24 hours.
Yep. Okay, thanks again.
Thank you.